So good evening, everybody. We are live now, and we can proceed.
Okay. Good evening, everybody. Welcome to this today's presentation, which is going to be by Dr. Arvind Gupta on clinical examination of the shoulder. As you know, the DNB theory exams have just been over, and in the near future, the practicals and the clinical exercises, clinical cases are going to be held. We are not sure whether it'll be virtual or in actual patients, but either way, the examination is important. You could get shown a slide of a clinical test, and you may have to sort of let the examiner know what the test is and what you hope to elicit by that test. So I think the clinical examination of the shoulder can be a little confusing for people, but if you go about it in a systematic way, you should be able to do a good clinical examination to come to a diagnosis. So I would request Dr. Arvind Gupta to start his talk and take us through the steps of a proper clinical examination of the shoulder. Thanks, Arvind. Over to you.
Thank you, sir. Thank you for the opportunity. Good evening, everybody. I'll be talking on the shoulder joint examination. It's basically exam-oriented, the examination of the shoulder joint is there. So, as any other examination, the shoulder joint is also start with the inspection, with the exposure of both the shoulder at the same time with upper chest and the back also. And this inspection should start with inspection from the front, in which we should see all the bony landmark, joint, muscle. Is there any muscle atrophy or swelling or anything else? Like in this case, we can see this part is prominent in comparison to other part. So lateral end of the clavicle is prominent there. So we can appreciate in the X-ray also where the lateral end of the clavicle is going high. So this is the fracture dislocation of the AC joint. Similarly, inspection from the back, in which any abnormality of the scapula, prominence of the scapula, the neck should also be inspected at the same time. So this is a case of a spinal shoulder. As well as we should also see the fossa, that is supraspinatus fossa, infraspinatus fossa for any muscle atrophy is there. Because many a time there is isolated infraspinatus muscle atrophy in comparison to opposite side. That is suprascapular nerve neuropathy is there. And if there is rotator cuff tear is there, then we also again find the atrophy of the muscle in the supraspinatus and the infraspinatus. At the same time, we should also look for a scapular dyskinesia, particularly those who are having the chronic pain in the shoulder joint. Right? Like in this case, we can see the medial border of the scapula on the left side is completely prominent is there. At the same time, there is hypertrophy of the trapezius muscle in comparison to opposite side. So this is a type 2 type of scapular dyskinesia. So this was a case of chronic type 3 AC joint dislocation, and the hypertrophy of the trapezius muscle was there to compensate for the AC joint dislocation. So this should also be focused when you deal with the chronic shoulder pain. Next is inspection from the side. In this case, we can see the complete atrophy of the deltoid muscle, and there is increased distance between the lateral end of the clavicle and the humeral head is there. Next is the inspection when the shoulder joint is abducted and flex elbow. In this case, we can identify the Popeye sign, which is basically the tear of the long head of the biceps. And usually patient have not any complaint, even patient not notice this, and patient remain happy with this. But when you do the abduction and the flexion of the elbow joint, this sign become prominent. So this is the Popeye sign. The next is the inspection for the winging of the scapula. This is the test for the serratus anterior muscle, in which the wall place on hand place on the wall with arm in abduction and do the push forward. and look for the prominence of the scapula. If there is symmetrical elevation of the scapula is there, usually serratus anterior place the scapula into the chest with this, into the back. But when there is injury to this serratus anterior or nerve supply to the serratus anterior, this border get prominent. So this is called as the winging of scapula on pressing over the wall. After inspection part is completed, then we should proceed for the palpation. Palpation should be done for all the bony landmark, all the joint line, like sternoclavicular, acromioclavicular joint, the glenohumeral joint, and the coracoid process. This is very important. One sign that is called as coracoid pain test, which is very sensitive for the frozen shoulder. All stiff shoulder are not frozen shoulder. So this test, that is coracoid pain test, help in differentiating whether it's true frozen shoulder or it's false frozen shoulder. When there is tenderness around the coracoid associated with the stiffness of the shoulder joint, very high sensitivity test for this frozen shoulder, because the coracohumeral ligament that is attached with the coracoid is the first structure which is involved in the frozen shoulder. At the same time, involvement of the biceps tendon in the bicipital groove for biceps tendonitis is also very sensitive test. Next is the range of motion. This the flexion is almost 180 degree, extension is 50 degree, abduction is again 180 degree, adduction is around 50 to 60 degree, and internal rotation, at least after placing the arm over the back, at least the lower border of scapula we should touch. This is the extended internal rotation, and the external rotation by the side, arm in the side of the body, and do the outward movement, that is the external rotation. For all these movement tests, the apply gives the apply scratch test with the opposite hand. If the patient is able to touch the upper border of scapula, then his external rotation and abduction is full. Similarly, if touch the lower border of scapula with the opposite hand, it means the internal rotation and the adduction is full. This is called as the apply scratch test. The newer test added is the cross body adduction test. This test is done by 90 degree of the flexion of the shoulder joint and the fully adduction. This test is very sensitive for the AC joint. So a shoulder is having very high range of motion. That is, in fact, the daily living activity is not needed that much amount of movement. So recently in Journal of Shoulder and Elbow Surgery in 2012, it was published what should be the amount of motion required for the daily routine activity. So flexion was only 120 degree needed, extension was 45 degree. Similarly, abduction is again around 40-50 degree less. Adduction is also only 25 degree was needed. Similarly, only 50% of the external and internal rotation was needed for the daily living activity. This is also very important, particularly while treating the patient for the shoulder joint pathology also. So whenever we are examining the patient for those who are having the shoulder joint pain, we should always keep in mind about the referred pain to the shoulder joint. The most common place is the cervical spine. Next is the myofascial trigger point. Apical lung cancer also presents same side shoulder joint pain. Angina on the left side. Similarly, any spleen injury on the left shoulder. Gallbladder on the right shoulder, and carpal tunnel syndrome also leads to referred pain to the shoulder joint. So these pathology also should keep in mind. Then after this generalized test, the special test is described around the shoulder joint, particularly for the rotator cuff tear, any instability, impingement, biceps tendon, and the AC joint disorder. We'll start with the rotator cuff tear. The first test is the job test, also called as the empty can test. Finish the 90 degree of the abduction of the shoulder and the 30 degree of flexion, forward flexion. In this, the humerus comes in the line of the supraspinatus. with the 90 degree of abduction and the 30 degree of forward flexion, and then do the fully internal rotation of the shoulder joint so that thumb is down. Now patient is asked to lift the arm against the resistance. So any pathology with this supraspinatus tendon, this test is positive. Only thing, sometimes subacromial impingement or pain because of any pathology in the subacromial space, this test also get positive. So sensitivity and specificity of this test is around 75%. Next is the drop arm test. This test is basically for the supraspinatus muscle. Again, sensitivity and specificity is around 70-75%. In which patient arm is lifted to 90 to 120 degree of abduction, and then patient is asked to do the slow downward movement of the arm, but he is unable to perform this because of the pathology of the supraspinatus, that is tear of the supraspinatus. So this test is called as drop arm test. Next test is for the infraspinatus, in which the arm is kept in the side of the body with elbow is 90 degree of flexion, and now patient is asked to do the external rotation independently and also against the resistance. If patient is having in doing this against the resistance, it means this test is positive. There is a problem with the infraspinatus also. But at this sidewise, the placement of the this shoulder joint, this external rotation at this position is also done by the posterior part of the deltoid. So to remove the effect of this posterior part of the deltoid, arm is placed in abduction, 90 degree of abduction, and this elbow is flexed at the 90 degree there. And in this position, now patient is asked to do the external rotation. And at this position, there is no effect of the deltoid over the this external rotation in 90 degree of abduction and 90 degree of elbow flexion.
Any problem, sir?
Little bit this is getting slow. This will get okay in couple of seconds. Sorry.
What is the issue, Janki?
This slide is not getting proceed.
Okay.
You can switch off and switch on, sir.
Yeah, stop sharing and share again.
Yeah. In between, if someone have any question, please ask. Sir is here to answer.
Till now it was going it was going okay, or it was
Yeah,
bumpy?
it's just fine. Fine, sir.
Okay.
No problem.
You can share again. No problem.
Yes, share screen.
This is a problem with your computer.
Yeah,
Not,
maybe
not with the light. Not
Yeah,
with the
Yeah.
light.
then this is
So close the thing and open it again and then see.
Yeah.
Close the presentation and open it again.
yeah. Meanwhile, we can do some discussion.
Yeah.
Yeah. So Yes. So I think one thing I want to mention here that probably this is important for all of you, that what we used to do mistakes while doing the shoulder joint, like we are usually not examining the patient from the behind. What mistake I have did while presenting it. And one thing which we used to forget is about the handedness. We should uh, tell the examiner about the dominant hand, which one is dominant hand of the patient, and uh, when we are uh, doing the examination, we should expose till the waist, and the we should also confuse for the range of motion of the elbow, that sometimes when it is like that, this is 90-degree, but this one sometimes we call it like 30 degree or so. So we should remember that this one is 0 degree. From here we can start the elbow movement, and so the range is also confusing. And when we are uh, telling the in the exam what is the range, then in that one, from the 0 we should start like 0 to 90-degree, not like 90-degree. That uh, that is a common mistake what we used to do when we are examining. And so
I think once the elbow range of motion, I think, is now should be fairly uniform. That 0 is full extension. Okay, so early on you would start from 90 degrees flexion, and then as you extended, you measured extension, and as you flexed it, you measured flexion. Okay, but now 0 degrees is full extension. If it goes beyond 0, it is hyperextension, and then flexion starts from that. At 90 degrees, it's 90 degrees flexion. Any more, it is 120, 130 degrees flexion. Okay, so I think that has now become fairly standardized. You just need to be sure that you followed this method rather than the older method of starting from 90 degrees and then working out your flexion and extension. Okay.
yes.
So, Arvind, you ready? Or
yeah, I'm ready. Can you see the screen? My screen?
Yeah, we can see your screen. Go to the next slide and then start. Yeah. Go to yeah. This is the one in abduction. Okay.
Yeah. So when shoulder is in abduction, so effect of the deltoid is not there. So here only the infraspinatus is working. So in this position, patient is asked to keep the shoulder in external rotation. If he failing to do this, it means there is problem with the infraspinatus. The next is the external rotation lag test is there. In which this test is for the supraspinatus and infraspinatus both, in which elbow is 90-degree flex and the shoulder is elevated in the scapular plane, and then external rotation is done by the examiner, and the patient is asked to keep in external rotation while holding the arm in the this 30-degree of flexion. If he is unable to do this, it means there is problem with the both supraspinatus and infraspinatus. Next is the drop sign. This sign is basically done for for the infraspinatus muscle with the arm is 90-degree of abduction and the external rotation. In this position, you can see the external rotation is done by mainly the teres minor and the infraspinatus only. So this test is done for infraspinatus and teres. Here you can see the external rotation was done by the teres minor and the external rotation. So if patient is unable to keep the arm in this external rotation position, this is called as the drop arm sign, drop sign test. Next is hornblower sign or the Pate test. This test is usually done with the 90-degree of abduction of the shoulder joint with the external rotation of the elbow. Flexion of the elbow with external rotation. Now patient is asked to bring both the hand to the mouth and look for there should not be any elevation of the elbow. That is the abduction, further abduction. This is the isolated test for the teres minor. The next is for this the subscap test. Subscap is the strong internal rotator of the humerus, which attaches over the lesser tuberosity. And this test is usually, there are three tests for the subscapularis muscle. The one is the lift-off test, another is belly press test, and next is the bear hug test. We'll see separately. The lift-off test, in which the hand is kept on the back and then lift the hand. And this lifting is done by the further internal rotation of the shoulder. So it means the subscap is working and with full strength. After doing patient, then this should be done against resistance also. If he is unable to perform this, it means there is pathology with the subscap. And the next test is the belly press test, in which hand is placed on the belly with 90 degree of flexion of the elbow. And now patient is asked to do the pressing of the belly. This can be done by the internal rotation of the shoulder joint, like this here. You can see there is internal rotation of the shoulder joint. And this is because of the subscap. When there is pathology with the subscap, this is not possible by the internal rotation. This is not possible by the internal rotation, and elbow fall back, so that this is done at the level of elbow only, not by the shoulder level. So when if you see when there is pathology of the subscap, this elbow is falling back. So this is not because of internal rotation of the humerus. This is because of humerus, elbow is falling back, and that leads to pressing of the belly. So when it is there, this test is positive. It means there is pathology with the subscap. The next test is the bear hug test, in which the palm is placed on the opposite shoulder, and this arm is get lifted from there by the examiner, and patient has to hold the palm at opposite shoulder. So when there is a problem with the subscap, this is not possible by the patient to keep the hand there. So this test is positive. This is called as the bear hug test. In all the three tests, there is internal rotators of the shoulder is active, that is subscap. When there is pathology with this, the internal rotation is not possible. It means the test is positive. Also, when there is a tear with the subscap is there, then there will be increased external rotation of the shoulder joint. You can see there is till that there is a normal external rotation, and once this subscap is torn from the lesser tuberosity, there will be increased external rotation. Now you can see there is excessive external rotation of the shoulder joint. So it means the excessive external rotation of shoulder joint is one of the sign for tear of the subscap. So these four tests is very important for subscapularis. So this patient was referred to me for repair of the supraspinatus, infraspinatus, and teres minor and subscap. All the rotator cuff pathology was torn and referred to me for this reconstruction. So repair, you can see drop arm test was positive. Patient was unable to do internal rotation of the shoulder joint as well as external rotation of the shoulder joint. And there was problem at the elbow also. You can see the flexion and extension was not possible here. And then the back examination was done. There was full mark atrophy of this infraspinatus fossa, supraspinatus. Whole deltoid was atrophied, and the shoulder was getting subluxated. So in spite of being all the tests for the rotator cuff tear was positive, and this patient was having problem with the elbow also. That should not be happen with the rotator cuff injury. So this patient was not able to flex the elbow or extend the elbow. You can see here. So patient was not able to do the flexion of the elbow as well as the extension of the elbow actively. So this was the pathology for the brachial plexus. So differentiation of both the sides, like sometime brachial plexus injury will diagnose as the rotator cuff tear, and sometimes rotator cuff tear is also diagnosed as the brachial plexus injury. So this differentiation is very important by doing the neurological test. So this was the case of brachial plexus injury and manage accordingly that. Though MRI was saying there is tear and atrophy of the supraspinatus, infraspinatus and all this. So clinical test is very important along with the radiological examination. The next is test for the instability, which may be provocative test or the quantitative test. Like for the anterior instability, this is the apprehension test, which is done in the 90 degree of abduction with 90 degree of flexion of the shoulder joint, and then the external rotation should be performed, like in this case. And this look for the apprehension of the patient. Patient will not allow to the further external rotation. So this is the apprehension test. Another test is the mid-range instability test. When the dislocation of the shoulder joint is associated with the marked bony lesion, either of the glenoid or very big heel sacs is there, then this test is called as the mid-range instability. Here you can see this instability is, mid-range instability is performed in around 45 degree of abduction only and the external rotation. And here the test is positive. It means this patient is having the problem with the bony problem also. This test was recently described by the Jody Beer and the Burkhardt. The next is the sulcus test, in which the elbow is flexed 90 degree and the downward traction was given to the shoulder joint, and look for the increased distance between the lateral end of the acromion and the humeral head. If it is more than 2 centimeter distance is there, then this test is again positive. Next is the jaw relocation test, in which patient is in supine with the 90 degree of abduction with the 90 degree of flexion, and the further external rotation will lead to subluxation of the shoulder joint. And this condition, when we apply the force downward, so that this shoulder joint get reduced and patient will have relief. So that's why this is called as relocation test. Next test is fulcrum test. Again, hand is placed under the shoulder joint in 90 degree of abduction, and the further extension of external rotation of the shoulder joint done, the patient apprehension will be appreciated. Next is load and the shift test, which is quantitative test. Stabilize the scapula with one hand and hold the humeral head with other hand, and do the anterior translation as well as the posterior translation. If anterior translation is almost more than 30% of the diameter of the humeral head, then this test is positive. And the posterior translation is more than 50% of the humeral head, then the posterior translation. It means there is laxity of the capsule joint, shoulder joint is there. Again, another provocative test is the jerk test. This is for the posterior instability. This is very important, particularly in thrower and those who are having the posterior labrum tear, in which the shoulder joint should be stabilized with one hand and 90 degree of abduction, and the internal rotation. Axial force should be applied, and look for any subluxation posterior-inferiorly. Very high sensitive and the specificity of this test, the posterior provocative jerk test. Some patient will have the multidirectional instability. This may be because of the generalized laxity, or this may be because of the scapular abnormal mechanics. And some patient is having psychiatric problem. They think they are supreme or Spider-Man type of thing, and they try to do the voluntary dislocation of the shoulder joint. So this, whenever there is voluntary dislocation, the generalized laxity should always be checked. Next test for the impingement syndrome, in which there is first is the painful arc syndrome is there, and abduction of the shoulder joint pain has started in between 60 to 120 degree. It means there is some pathology in the subacromial space or rotator cuff tendon. The next is the knees impingement test, having sensitivity and specificity in between 60 to 70%. When is the arm is abducted and flexed in between, and then internally rotation of the shoulder joint is done, and look for any pathology in the subacromial space. Informed patient will say there is pain or weakness. You can see the greater tuberosity comes under the acromion, and this leads to the pain. So next is impingement test by putting the xylocaine under the shoulder joint. And if this pain of the knees impingement goes, it means there is pathology in subacromial space, and this become confirmatory test. Next is the Hawkins-Kennedy test. It is done with the 90 degree of the flexion of the arm with full internal rotation of the shoulder joint, which look for any pain there. This test is positive, and there is pain or weakness in this case. So this is for the Hawkins-Kennedy. The next is for the Yoakum test. This is almost like Hawkins-Kennedy test only. Only modification is the 30 degree forward flexion of the shoulder joint. So again, this test is for the impingement. The next is the internal impingement test. All the test was external impingement test that was outside the capsule. So next is the internal impingement test, in which the shoulder is in abduction and the external rotation. And in this position, if there is infraspinatus impingement occur in the superolateral aspect of the glenoid or the labrum, then this test is positive. Here you can see the infraspinatus get impinged over the superolateral aspect of the glenoid. So this test usually positive in case of thrower, those who are regular thrower having this test positive. Again, this test having sensitivity and specificity is more than 90%. The next is a test for the biceps tendon. The first is tenderness in the bicipital groove. Then the Yergason test, sensitivity is low, but specificity is very high. This test, the arm is in the side of the body with elbow is 90 degree of flexion, and the patient arm get hold by the examiner in the pronated position. Then patient is asked to do the supination of the forearm. This test is basically by the transverse humeral ligament. When it is torn and patient try to do this supination of the forearm, this biceps tendon get dislocated from the bicipital groove, and patient will have cruciating pain. So specificity is very high, but sensitivity is not very high. Next is the speeds test. Again, specificity is high, in which the arm is in 30 degree of flexion, and the elbow is fully extended and the supinated. And then patient has to raise the arm when against the resistance by the examiner. And when the pain get appreciated in the bicipital groove, this test is positive. This test was discovered by the Speed, and when he used to do the straight leg raise for examining the spine patient, he has pain in the bicipital groove. Now there is modification for this Speed test, which was done in 90 degree of flexion of the shoulder joint with full extension and supination, and patient has to raise this. Next is test for the slap lesion. Slap is the avulsion of the superior part of the labrum, anterior and posterior, where long head of the biceps get attached. This is the O-brand test, having sensitivity is high, but specificity is not very high, with the 90 degree of the flexion of the shoulder joint with 10 degree of the adduction with maximum internal rotation. Thumb is down. If patient is having pain in the shoulder joint in this condition, it means this test is positive. And this pain usually goes when thumb is up. That is the external rotation of the shoulder. The pain goes up. This means the O-brand test is positive. Next is the crank test, in which the shoulder is abducted to the 90 degree and the internal and external rotation of the shoulder joint is done, and look for any clicking, catching sensation. This is again for the superior labral tear. Next test is done for the AC joint disorder, in which the movement usually occur in between 120 to 180 degree, and any tenderness around the in the AC joint there is very sensitive for AC joint problem. Also, patient will have problem in lying down on the affected side of the shoulder if there is any problem of the AC joint, because on lateral lying down position, all the force get transmitted from the AC joint. So this get painful. So patient will give history when he used to lie on the affected side of the shoulder, he is having pain in this area. Next test for the AC joint is cross body adduction test, in which the arm is flexed 90 degree and fully adducted, and patient is having pain because of the adduction. There is problem with, if there is problem with the AC joint. Next, again, a very specific test for AC joint is the O'Brien test, in which on doing the internal rotation and the movement, again the resistance, this humeral get in contact with the acromion, and if there is problem with the AC joint, this get up, and that leads to pain to this joint. Thank you.
Okay, so any questions?
Yes, sir. In the chat box, Amit and Gautam has asked few questions.
Okay.
Amit has 3 tests which are very confusing for him, which require flexion and internal rotation. These are job test, knee impingement sign, and O'Brien test for slap lesion. So, can you please explain to that one, sir?
Yeah. So in job test, the shoulder is abducted and fully internally rotated. For O'Brien test, the shoulder joint is flexed and adducted. So in O'Brien, you have to do ADD, and in job test, you have to do ABD. Okay. And in knees test, there is full flexion of the shoulder joint with internal rotation. So in knees test, there is full flexion. In job test, there is full abduction, so that your shoulder, this humerus comes in the line of the supraspinatus, and then the thumbs is down. This is also called as empty can test. And for O'Brien, this is adduction, ADD, with internal rotation of the shoulder.
Sir, Gautam wants to know, can anyone quantify the pathology of severity of clinical test by clinical test only?
Yeah, like for subscap lesion, if this lift off test is patient is able to do against the resistant, but not fully, it means there is minor injury. Patient can do without resistance, but not against resistance, it means there is moderate grade of injury. And even without any resistance, patient is not able to do, it means there is severe injury to the subscap. So there is quantification also, like sulcus test also. If it is 2 centimeter, then this is the mild laxity. If it is more than that, it is moderate or severe laxity. Similarly, there is translation of the humeral head with load and shift test. If there is 30% anterior translation, there is mild laxity. If it is 50% translation, moderate. If it is excessive translation, it means very severe laxity of the shoulder.
Thank you, sir.
You showed a whole lot of tests, okay? In one patient who you see in the OPD, it's not possible to do all the tests, I presume.
Yes.
So which are the absolute essential tests in the exam which the exam candidate should show and demonstrate during his clinical examination?
Inspection.
Say, suppose it's a patient with suspected rotator cuff pathology.
Yeah. So after inspection and palpation, the standard examination part, if a student comes to the standard test, this special test, then at least he should describe the job test, that is empty can test, that is for the rotator cuff, the supraspinatus. Then for the infraspinatus, at least external rotation lag test. And then for the teres minor, this is the Pate test. or the horn blower. So at least one test for supraspinatus, one for test for the infraspinatus, that is external rotation loss, and the third test, that is horn blower test for teres minor. And for the subscap, at least lift off test. These 4 tests having the sensitivity and specificity higher than any other test. So all these 4 tests for this rotator cuff tear should be done. And for impingement, though Hawkins-Kennedy test having sensitivity and specificity is more than the Near's impingement test. But the Near's impingement test is described very earlier. So at least Near's impingement and Hawkins-Kennedy, these 2 tests should be described by the student to the exam.
And sir, for instability?
For instability, apprehension test is very easily can be done, and it should be at 90 degree of abduction and 90 degree of this flexion of the elbow joint. The full external rotation should be tried. In this case, patient will try to escape the full external rotation. So apprehension test is should be performed. This is very sensitive test.
Sir, Amit has one more question about the frozen shoulder, sir. He wants to know how to diagnose frozen shoulder clinically, being it a diagnosis of exclusion.
So frozen shoulder, usually in our practice, all the shoulder having restriction of the movement is taken as the frozen shoulder. But it is not like that. This restriction may be because of AC joint arthritis, because of pain, maybe subacromial bursitis, maybe rotator cuff pathology will have this restriction of the movement. So the basic pathology of frozen shoulder is the coracoacromial ligament get thickened. So this start with the restriction of the external rotation, and later on as inflammation progress, this leads to the inflammation around the capsule and the synovial. So slowly all the movement get restricted. So for frozen shoulder, restriction of external rotation is very important. So if there is full restriction of movement, but external rotation is almost more than 50 degree or 60 degree type of thing, so this is not a case of frozen shoulder. At the same time, the test called as coracoid pain test. If tenderness within 2 centimeter periphery diameter of this coracoid bony landmark, tenderness is there, then this test is very sensitive and specific for frozen shoulder. So this test also should be kept in mind.
So also remember, don't use the term periarthritis. Okay, so this is a term which should not be used one way or the other. Okay, it's a term which has been used for frozen shoulder. I think adhesive capsulitis or frozen shoulder are acceptable, although we still don't know clearly what the pathology is, but certainly periarthritis is not what it is in pathology or in terminology. Okay.
So you have mentioned about the teres minor test, but teres minor is a very thin muscle, sir. So that is isolated tear of teres minor. Is it common, sir?
It's not very common. It's very rare, and usually teres minor works with the infraspinatus. So for the independent teres minor test, this is the horn blower. When the arm is abducted to the 90 degree and the elbow is flexed, and also the full external rotation of the elbow joint, shoulder joint is done. Now in this position, external rotation, patient is asked to touch the mouth. So if teres minor is intact, this can be done. But when teres minor is torn, in spite of being intact, the infraspinatus, this shoulder, this get full more abducted to bring the arm down to the mouth. That's why this is called as horn blower test. And in rest other, it's always work with the infraspinatus. But there is isolated tear of this infraspinatus. But
So,
mostly.
So also you should know why the tests are called a particular thing. Okay. So for example, horn blowers test. Why is it called a horn blowers test? Because you need to get the arm into that position to blow the horn, okay, for whatever either your musical instrument or for blowing a horn for any other reason. It's not like horning your car, but blowing a horn, okay? So like a conch or something like that, if you want to compare.
So otherwise,
it's not named after any person. So don't say hornblower was a famous surgeon or something like that if someone asks you about that. Similarly, the Napoleon's belly press test. Why is it called Napoleon? DNB guys?
Don't know, sir.
You should know.
Yes, sir.
So Arvind?
Sir, please.
So this is after the famous Emperor Napoleon Bonaparte, okay? He used to keep his hand, and you see any photograph of his hand is there on his belly.
With
Okay?
the coat, yeah.
Yeah? So that's why it's called, it's got nothing to do with any person who's described the test. Okay, so although a lot of the other tests are named after surgeons who've described the test, remember that some of these are based on, like, for example, you have another classical example of the scapholunate instability called the Terry Thomas.
Terry.
Okay?
Yes.
It's based on a
UK, this UK.
The gap between the
gap in his teeth, okay?
teeth.
Yeah. So that's why it's called Terry Thomas test, not because some famous surgeon by the name of Terry Thomas described that test, okay? So try to get to why a particular test is named. Is it after a surgeon? Is it after a person, or after some other peculiarity that it's named? Okay.
So sir,
yes, the surgeon, some examiner might just want to ask you that, especially if you take the name. Okay, if you just say belly press test, he may not ask you about Napoleon, but if you say Napoleon, he might ask you, well, who was Napoleon? Yeah.
Sir, sorry to ask, but what is the relevance of this history part?
Which history part?
मतलब सर किसी भी ऑर्थोपेडिक सर्जन के नेम्ड है उसका हिस्ट्री पूछते हैं एग्जाम्स में.
Because the examiner can ask you why is it called that. Okay, if
yes, मतलब उसका रिलेवेंस क्या है सर? मतलब why anyone should know about the
contribution of someone.
So
because if you want to understand why it's called that, then you need to know that. Yeah.
Okay, sir.
You just want to cram it and say it, that's a different thing altogether. Okay.
Okay.
I think it's more important to try and understand why something is called, then you'll understand the test better as well. Yeah.
Yes.
And also easy to remember. If you can. So, sir, for that one belly press test and lift off test, that is for infraspinatus as well as teres minor.
So this is for the subscap. See, belly press or lift off is required for internal rotation of the shoulder.
Okay.
Yeah. So if you see the shoulder when you do the belly press, it means the internal rotation of the shoulder is needed. So subscap has to be there to perform that activity. If subscap is not there, it means this test will not be performed. So this test is positive. So for lifting the palm from back of the your back, this leads the further internal rotation of the shoulder. In that only, so you can lift the palm from your back. So this subscap has to be intact for that activity.
Arvind, I think another important thing would be if you would demonstrate what we mean by flexion extension in the shoulder because of the plane of the scapula, okay? Because everyone talks about flexion going straight forward, but when you're talking about flexion of the shoulder joint, you're talking about a specific motion. Yeah. So if you can demonstrate it, if you can stand up and demonstrate it to everybody so that they understand what plane they should be talking about flexion or demonstrating flexion, extension, etc.
This shoulder is fine, sir.
Yeah.
So normally scapula is in 30 degree of flexion is there. So there is two type of flexion. One is along the body side. If you do in the plane of the...
We've lost your net.
Yes.
Okay, so we could,
Yeah.
Arvind, we've lost you.
Sir, I think few of the examiner accept that forward flexion this way also, and few
Yeah, so, but
need,
you should be clear about what you're
yeah,
showing so that you can explain the, so when you say forward flexion, you're talking about straight. That's why you call it forward flexion, okay?
yes,
Flexion in the plane of the scapula, then it's at a slightly different plane, okay?
yes,
So you should understand the plane of the scapula as well, okay?
yeah. Avinash and Sumit must have some questions. Avinash, you can ask now. In between, Amit has one question, sir. He want to know how is that in cubitus varus deformity, internal rotation of shoulder is increased?
So what is a cubitus varus deformity? Amit?
Yeah, Amit.
Sir, it is the deviation of the forearm from its normal axis outward towards outwards, away from the body.
Outwards. Forearm away from the body is cubitus varus. That's interesting.
Elbow away
valgus.
from
It is
body.
valgus, sir.
So
It
you
is
ask,
towards the body. It is towards the body. Deviation of the axis of the forearm towards the body.
okay, so now do you think it's a pure coronal plane a deformity or there's a rotational element to it?
There is a rotational element to it.
So which way is the rotation?
Towards the medial side.
Internal rotation, okay?
Yes, sir.
So if you check the arm, the rotation will be more internally than externally, okay? Because distally it is more internally rotated, okay? After all, you're looking at the elbow when you're looking at rotation. Huh? You're not looking at the shoulder. You understand what I'm trying to say?
No, sir.
So if you keep your hand straight, okay? Okay?
Okay,
Now,
sir.
if your distal humerus is internally rotated, to keep it straight, you're going to have to externally rotate it.
Okay, sir. Now I get it.
Yeah?
Yeah.
So automatically you have, it's like femoral anteversion. Okay, if you have more femoral anteversion, you'll have more internal rotation in your hips than external rotation. Okay, so similar.
Yes, sir.
Yeah.
Thank you, sir.
Sure.
And Avinash?
No question.
No questions.
Avinash knows it all. Yeah.
Sir, on the
So we
basis
should
of
ask Avinash some questions now. Janki, you have got.
Yeah. So you should know what are the common cases you get from the shoulder joint in your exam.
Yes.
You should know that at least. Yeah. You please tell.
So,
Okay. You know what is carriage sikka? The common thing first.
no.
Caries.
presentation, we are
It's
Carriage
caries
sikka.
sikka.
Yeah. Yeah.
The tuberculosis.
Yeah. So what form of tuberculosis is it?
Yeah. Anybody else?
it is
It's a
dry.
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 So,
Sir,
Sumit?
I have one question.
Yeah.
Sir, on the basis of shoulder rotation, how to differentiate between supracondylar and lateral condyle injury?
Why would you want to decide that on basis of shoulder rotation?
No, sir. Such as just suppose delay non-union supracondylar or delayed
So then
malunion of
you would look at the elbow. Why would you? I mean, to differentiate. So in a supracondylar fracture, what's the usual deformity?
Yes.
Cubitus varus.
And what's the deformity in a non-union of a lateral condyle fracture?
Valgus.
So valgus deformity. Then you'll get
Yes, sir.
You might get instability, okay?
Yes, sir.
So
Some examiner asked, sir.
So you can tell by if there is more internal rotation, then it's likely to be a supracondylar fracture, okay?
Yes, sir.
Post-supracondylar fracture. It's unlikely to, but you would not do that to make your diagnosis, okay?
And you should have a history of trauma also in that case. So
yeah, either way, for either fracture, you need a cubitus varus also, you'll have a... Arvind is back.
Yes.
Okay,
So, sir, we have lost you in between.
Arvind, are you back or you're still...
No, sir, has...
Yeah.
Yeah. But it's...
So, yeah, I have connected with another network. So,
Okay.
I am there. I'm visible.
Yeah, we can... Yeah,
so,
okay.
So, this is the coronal plane. So, this flexion is in
Not
coronal
visible,
plane.
No.
Sir, camera is not on, sir, I think.
Yeah.
No, we can see him.
So, yeah, so it is not there.
Yeah, you please demonstrate, sir. Then after that, you can explain to us. Because
so this is the coronal plane and this is sagittal plane, okay? So in this coronal plane, this is the extender, the flexion, and this is extender abduction. This movement is extender. But when we say in the plane of the scapula, so this is in between the extender abduction and extender flexion. So if you do like this, this is the flexion in the plane of the scapula. So almost around 25 to 30 degree from the coronal plane. So this is the flexion in the plane of the scapula.
So isn't it the other way around? It's turned in, isn't it?
Pardon, sir?
Scapula is internally rotated in respect to the thorax. So there's anterosion of the glenoid.
Yeah, so there is...
so won't it be in slight adduction rather than abduction?
In between the flexion and the abduction in the scapular plane. Because direction is something like this, not like this.
Yeah, the abduction will be in that plane, but flexion will be more anteriorly, more medially. Yeah?
Yeah.
Yes, sir. That's true, sir.
Yeah.
So,
direction of the glenoid is like this. In this direction.
So that's what. So flexion will be at right angles to that.
Yeah.
Which will be slightly more medially than laterally. Well, abduction will be between the planes of flexion and abduction. Yeah?
Yes, sir.
Okay. So is that, I think that should be enough because it's already 7:30.
Yes.
Okay. So thank you, everybody, and thank you, Arvind, for an excellent presentation. And I think we should now call it a day.
Yeah.
Thanks, Ashok, as usual, if you're still there.
Yeah. Sorry, sir.
His photograph is there. It's probably dealing with some other webinar somewhere. Okay. So
thank you. And one more thing I want to say about that, we have one series of classes on omniculus also, which is about the surgical techniques, and we have ankle fracture surgical tips and techniques tomorrow at 6 p.m. So
it's not just surgical, it's not basically surgical technique, it's about periarticular fractures basically.
Yeah, mainly periarticular fractures.
Tomorrow we are going to talk about ankle fractures, understanding them and how you deal with them.
Yes.
Okay.
So
okay. So
thank you, sir.
Yeah, see you tomorrow.
Thank you, sir.
Sure.